Kidney stones are hard, mineral-like deposits that form inside your kidneys. Think of them like small pebbles forming where they should not be. The medical term for these stones is renal calculi, nephrolithiasis. When these stones form anywhere in the urinary tract, such as the ureters or the bladder, the condition is called urolithiasis. These stones can create significant problems. They can block the normal flow of urine from the kidneys down to the bladder. This blockage can cause immense pain, lead to infections, and in severe cases, damage the kidneys. This lesson is designed to make this topic simple and clear, especially for those preparing for the NCLEX exam. It will walk you through the essentials for safe, effective patient care. The journey of a kidney stone can be unpredictable. Some stones are as tiny as a grain of sand and pass without symptoms. A person might pass a small stone and never realize it happened. However, other stones can grow much larger, sometimes as large as a pearl or even bigger. These larger stones are the ones that typically cause trouble. As they travel down the narrow ureters, which connect the kidneys to the bladder, they can get stuck. This leads to the sudden, excruciating pain that is the hallmark of a kidney stone attack. Understanding this basic process is the first step in caring for patients with this common painful condition. Certain individuals are more likely to develop kidney stones. Dehydration concentrates urine, making crystals easier to form. Diet matters. Very high protein, high sodium, and high sugar increase risk. Family history, gout, UTIs, and hyperparathyroidism also raise risk. A thorough patient history is crucial. Kidney stones do not appear out of nowhere. They form when there is an imbalance in substances that make up urine. Normal urine contains chemicals that prevent crystals, but sometimes these protectors do not work. When urine has more crystal-forming substances like calcium, oxalate, and uric acid, then it can dilute. Crystals begin to form. Tiny crystals join together and grow into a solid stone. The process is slow and silent until the stone moves or blocks urine. Inadequate fluids concentrate urine and set the stage for stones. Knowing the type guides treatment and prevention. Most common, calcium stones, usually calcium oxalate. Oxalate comes from foods like spinach, nuts, chocolate, and is also made by the liver. High vitamin D, metabolic disorders, or intestinal bypass can raise calcium or oxalate in urine. Calcium phosphate stones are linked to conditions like renal tubular acidosis. Because calcium stones are most frequent, dietary modification is often central to prevention. Uric acid stones form with poor hydration, excess fluid loss, or high-protein diets. They are common in gout and with acidic urine. Treatment may alkalinize urine and limit purine-rich animal proteins like red meat and shellfish. Struvite stones form in response to urinary tract infections and can grow rapidly. They can become large staghorn calculi, filling the collecting system. Cystine stones result from hereditary cystinuria and may begin in childhood, requiring lifelong management. The most classic sign of a kidney stone is sudden severe pain, renal colic. It starts in the flank, the side between ribs and hip, often sharp, cramping, relentless. As the stone moves into the ureter, pain may shift and radiate toward the lower abdomen and groin. Patients are restless, pacing, sitting, then standing, seeking relief. Hematuria, blood in the urine, may make it look pink, red, or brown like cola. Sharp edges scrape the ureter lining, causing bleeding. Sometimes blood is only detectable microscopically. Other symptoms include dysuria, urgency, and small urine volumes. Significant blockage can cause oliguria or even anuria. This is an emergency. Pain can trigger nausea and vomiting via shared nerve pathways. Fever and chills behind an obstruction raise concern for urosepsis. Urgent attention is critical. Start with urinalysis. Look for red blood cells, white blood cells, crystals, pH, and specific gravity. CBC may show elevated WBC, suggesting infection. Monitor BUN and creatinine. Rising values signal kidney stress from obstruction. Electrolytes and calcium can reveal metabolic contributors. Definitive diagnosis. Non-contrast helical CT, fast and detects nearly all stones. CT maps size, location, and hydronephrosis. Ultrasound is a good alternative when radiation should be avoided. KUB is quick but limited. Sees calcium stones, not uric acid. It may track a known stone but is not the best initial test. For NCLEX, know that non-contrast CT is most accurate. When a patient arrives with classic kidney stone symptoms, the first priority is pain. Assess pain, rate 0 to 10, note location and characteristics. Administer analgesics. NSAIDs are first line, for example ketorolac. If NSAIDs fail or are contraindicated, opioids may be given. Reassess pain after medication. Address nausea and vomiting. Give an antiemetic such as ondansetron. If vomiting persists, start IV access for rehydration and medication delivery. Encourage small sips once nausea is controlled. Rely on IV fluids if PO is not tolerated. Monitor for infection and obstruction. Fever and chills are major red flags. An obstructed infected system is a urologic emergency. Take full vitals, notify the provider, obtain blood and urine cultures before antibiotics, and prepare for urgent drainage. Monitor urine output closely. Sudden decrease or anuria requires immediate notification. Have all patients strain urine using a strainer or fine mesh to capture the stone. Send any captured stone for analysis to guide prevention. Smaller stones, typically under 5 mm, often pass spontaneously. Supportive care includes oral analgesics and high fluid intake, 2 to 3 liters daily. An alpha blocker like tamsulosin may relax the ureter, easing passage and reducing pain. Stones that are too large cause unbearable pain, infection or kidney damage, need procedures. Extracorporeal shock wave lithotripsy uses focused shock waves to fragment stones for passage. Ureteroscopy visualizes the stone directly to remove it or laser it into pieces. Teaching must be clear and simple. Hydration is number 1. Aim for pale yellow urine. Teach red flags requiring ED care: fever over 100.4 dgF, severe uncontrolled pain, inability to urinate, or continuous vomiting. Reinforce prevention: reduce sodium and limit animal protein. Avoid high oxalate foods when appropriate. Encourage follow-up to confirm passage and monitor for new issues. Understanding renal calculi is must-know for NCLEX and nursing practice. Kidney stones are hard mineral deposits that cause severe pain when they move or block urine. Classic presentation: sudden intense flank pain, possible groin radiation, blood in urine, nausea and urinary urgency. Priorities: manage pain, ensure hydration, watch for infection and obstruction. Diagnostics: urinalysis and blood tests including BUN and creatinine. Definitive imaging: non-contrast CT for size and location. Treatment: fluids and analgesics for small stones, lithotripsy or ureteroscopy when needed. Severe pain: assess, give analgesics, reassess. Nausea and vomiting: give antiemetics and provide IV fluids. Blood in urine: collect urinalysis and monitor output. Fever and chills: obtain cultures, notify the provider, prepare for antibiotics. Possible urologic emergency: decreased or no urine. Evaluate for obstruction and alert urgently. Remember: pain, fluids, strain, and watch for fever. With these principles, you will manage renal calculi safely and effectively, and succeed on the exam. Visual: simple infographic summary: pain, fluids, strain, watch for fever.